Why heart attack is happening in young Indians? People are confused that he is fine, okay. Tomorrow, all of a sudden, he has a heart attack and they die.
Have risk factors right from any age, maybe around excessive gymming or aggressive
Workout. So, heart attacks can happen in marathon runners?
heart attacks. One of the most important preventable factor is smoking. So that is the one message. Only if it goes through whole of this, quit smoking. Younger patients, there is no benefit from it, but the risk is multiplied.
Smoking kills you. Why there is increased heart attack in patients in South Asians, India, Pakistan, Nepal, Bhutan, Bangladesh, Sri Lanka. The problem with our Indian community is this abdominal compartment is small. Should every person should know at least how to do CPR?
We're trying to educate because CPR saves life.
Working night shift puts an undue strain on the heart, isn't it?
It is and I think so it's very important to say stop when the body says please stop.
Yeah, exactly. Listen to the body. In your practice, when you talk to people, is lack of sleep is a common thing?
It is. Mobiles while sleeping also continue to see their Netflix and Amazon. I think so more than anything else, proliferation of OTT channels,
Wider availability. So much content.
so much content and it's addictive. Over a period of time, eats into your sleeping time.
Hello guys, welcome to another episode of our podcast series Gut Feeling with Dr. Pal. In this episode, we have my friend Dr. Anup Taksande, who is a very popular cardiologist in Mumbai. He has been putting stents in the hearts on a daily basis. We talked about a lot of things about acute heart attack. Why are people having heart attack at such a young age, and why people are actually dropping dead who are completely normal the day before? What is the reason behind it? What can we do to prevent this, and what can be done while the heart attack is happening so that we can actually save lives? Some tips and tricks for you to actually adopt, and you can actually save a life if your friend or a family member is having a heart attack right in front of you. How to diagnose it, what are the symptoms, and what are the treatment options. More importantly, we discussed about how to prevent it, what are the lifestyle measures that you should take, and he himself shared some personal stories about how he takes care of himself being a cardiologist, how he takes care of his heart. It was a wonderful episode. Let's dive deep into it. Hi, Dr. Anup.
Hello.
Hi again.
Yeah.
Thank you so much for coming back again.
Thank you so much. Pleasure is all mine.
So, we had a wonderful discussion last time. Wonderful discussion. We talked about heart disease, how heart disease is formed, what are the risk factors, what are the things that can be done to prevent the heart attack.
Yes.
Right? Now, we are going to talk about the most pressing problem.
Yeah.
Why heart attack is happening in young Indians.
Wow.
Sudden cardiac death. People are confused that he is fine, okay.
Right.
Tomorrow, all of a sudden, he has a heart attack and they die.
Right.
And we're looking at 25 to 35 years
Right.
old people.
Right.
What is the most important reason for this?
Right. So, very pertinent point for my younger patients, for my younger audience. Heart attacks.
Heart attack.
They don't look at any age. So you get attacks right from, you have risk factors right from any age, maybe around 20 onwards.
You said as young as 18, huh?
18 also.
18.
18 also.
Do you remember that patient? What was the patient about?
Yeah. So he went to gym.
Gym.
Yeah. He was a gymmer.
Hmm.
So probably in that case, the etiology, the risk factors might be different. As a medical practitioner, we are all aware, excessive gymming or aggressive beyond the limits, high intensity can lead to small dissections, possibly. That's why we hear so many celebrities, hardcore, prolonged gymming, not listening to the body. At times, marathoners, 40 kilometers, collapsing last moment. What happens is like some dissections, in especially the younger crowd, aggressive when they're doing workouts. Small dissections like small flap which forms inside the innermost layer of the heart blood vessels, endothelium. That small dissections, when exposed to the platelets, can form a plug in a patient who is at risk of, not everyone gets it,
Correct.
but who is at risk, genetically predisposed, and other factors are also there. So that platelet plug which is formed inside a vessel which has small wear and tear or dissection can lead to a sudden clot formation and leading to a heart attack.
Heart attack.
Okay.
So summarizing is the lining of the blood vessel is damaged to start with. Very friable. And then when you do an excessive workout,
it can lead to small dissections.
Dissection is disintegrating like this.
Disintegrating of the blood vessel innermost layer, but that can lead to platelet plug formation. And that sudden platelet plug formation can lead to a major attack.
Platelet is the blood clotting mechanism of your body, and that cell can get attracted to this dissection and forms a complete block.
Yeah, that is in a special scenario. We're talking about an 18-20-year-old aggressive gymmer. Otherwise, not everyone, obviously, can't equate that everyone going to gym is going to have this. No, someone has to be genetically predisposed.
So we can repeat that statement again. So the point is that you should not go to the gym. The point is there are certain group of patients they are at slightly at increased risk when they are doing aggressive workout, which they have not done before.
Right.
That could predispose to this platelet plug formation.
Yes.
While we are in that discussion, you heard about the Garba attack.
Yeah. Garba
in Gujarat.
No, I was not aware. Yeah.
So they don't know about it. We don't know about it. So in Garba, people were dancing.
Yeah.
And then all of a sudden, everybody died.
Acha.
They were dancing for hours together, 6 to 8
dehydration.
hours. Dehydration, exertion.
Yeah.
And
so that's what possibly happens in ultra marathons. So
let me rephrase the question.
Yeah.
So heart attacks can happen in marathon runners?
Heart attacks do happen. Every year in Bombay, we have the standard chartered marathon, which is approximately 40-42 kilometers. In humid conditions of Bombay, someone who's not well trained, well hydrated, what happens during that extended period of exertion, the blood pressure, the cardiac output, the heart functioning, it remains an extreme high. Can lead to formation of that small dissections we talked about. But apart from that, the dehydration, there is a cell concentration inside the blood vessel. That dehydration, cell concentration, sticky platelets, small dissection, everything can lead to small blood clot formation, which can lead to attack. So it's very pertinent that you keep yourselves hydrated, that you have a proper workout and a proper schedule wherein you train well rather than jumping directly. Extremely important.
So it doesn't happen on all patients, and even when that happens, it can be prevented by proper, well-trained schedule. It doesn't mean that you should not run marathon at all.
Absolutely not.
Because physical activity is very important.
Physical activity is extremely important, but again, you have to train yourselves well. The conditioning has to be there. You don't jump into something without any preparation, without any training. And important is to keep yourselves hydrated. And again, listening to the body is important. If you feel discomfort, I think no shame in stopping, no problem.
Yes.
Rather than pulling on and on.
Correct.
So every year around 5 to 10 patients in the whole marathon fall sick. 1 to 2 patients casualties do happen. So important message is nothing should stop you from doing that marathon, but listen well to the body, prepare well, keep hydration at hand, and if you have any discomfort, please stop. It's important. So young patients, we talked about gymming.
Correct.
We talk about marathons, but apart from that, these are the minuscule population.
Very minimal.
So we don't focus on it here. But when we talk about the major risk factor, in younger patients, again, as we talked about in the previous episode, Indians do get coronary artery disease 10 years earlier than the Western counterparts. Multiple reasons, multiple factors. Younger patients in India tend to suffer. And one of the most important preventable factors is smoking. So that is the
Most
one
important.
message, only if it goes through whole of this, quit smoking.
Okay.
Younger patients, there's no benefit from it, but the risk is multiplied.
Smoking kills you.
Smoking kills. It's hazardous risk. So if I do angioplasties, primary angioplasties in younger patient, less than 30, 35, we can say 35 years, less than that, 90%, more than 90% of them would be smokers.
Mm.
That's the most important
Wow.
risk factor. More than 90%. There are certain genetically predisposed, you can say, or at times dietary, you can say. If we had a lot of patients B12 deficient, that leads to a factor increased hyperhomocysteine. The homocysteine is increased. That hyperhomocystinemia
Can cause
can cause lot of
thrombosis.
thrombosis, aggressive thrombosis. So we had patients,
Is it right?
no risk factors,
Ah,
hyperhomocystinemia, high homocysteine
because of low
B12
B12.
deficiency.
Vegan.
Almost vegans, vegetarians, leading to that. So again, calls for taking that supplementation properly,
Correct.
because most of them are smokers. We can identify hyperhomocystinemia in certain group of patients.
Again, very minimal.
Yeah, but again, the gymmers and the marathoners are very, very minuscule.
Correct.
But then young patients, they all count.
Mm.
So you should be taking into consideration. But one thing, the message should be clear. You should do your physical activity under supervision. The
No
diet
smoking.
should be proper, and the smoking is an absolute
No.
must know.
I had a patient who had a heart attack and then he was smoking. And then I said, why are you smoking? And he said, my doctor said smoking causes cancer. He never said smoking causes heart attack.
That's a very funny statement, but I think that's
Smoking
message
is
should be,
one of the main important things.
that should be very clear.
There is a advertisement.
Yeah.
It was a wonderful creative advertisement
Yeah.
where the guy smokes
Yeah.
and then he falls, had a syncopal attack
Yeah.
kind of thing.
Ah.
He falls down on the floor, unconscious. And the smoke is basically, the cigarette is lying on his heart.
Oh,
And then slowly it is disintegrating, right?
Wow.
So that's one of the beautiful things that
Right.
The other thing that I like about this creative advertisement of smoking is smoking causes impotence.
it is.
So they show the smoking and the smoking goes like this.
Right. So there is one saying in cardiology, erectile dysfunction
Erectile dysfunction.
is preceded by endothelial dysfunction. We talked about the endothelium.
Yes.
So ED is ED. That predates that. So before you get anything, you have endothelial dysfunction, which someone has an endothelial dysfunction, high chances he will have
A patient with erectile dysfunction has endothelial damage.
The
The same
dysfunction.
endothelium can also be in the heart and can cause...
Same. So endothelial, what happens is it releases nitric oxide, which is a vasodilator. We know that, which is important in the patients with
Correct.
erectile dysfunction. But endothelial dysfunction is the first,
Wow.
you can say,
Amazing.
this dysfunction to happen before. This is an end product. Endothelial dysfunction is at the heart of this erectile dysfunction as well.
Wow.
ED is ED.
Wow.
That's what we say.
It is. While we are in this discussion,
Yeah.
So it's very clear that young people are at increased risk of heart attack because of multiple stress and all those things we
Yeah.
talked about.
Yeah.
But more than that,
Yeah.
our South Asian community is at increased risk, right?
Yes.
So I'm a part of a very small. I play a small role
Yeah.
in a study called Masala study.
Okay.
Okay, it's called Masala. MASALA.
Right.
MA stands for Metabolic Associated.
Oh.
SA stands for South Asians.
Asian. Okay.
LA is living in America.
Oh, wow. Masala.
Masala
Nice. Huh? Oh, wow.
Masala study.
Yeah.
what this study is focusing on, why there is increased heart attack in patients
Right.
in South Asians, India, Pakistan, Nepal, Bhutan, Bangladesh,
Bangladesh.
Sri Lanka.
Yeah.
Okay. And as you know,
Yeah.
like similar to me, there are so many people migrated from these countries
Yes.
into US.
Right.
So they are studying why are these people dying of heart
Dying.
attack, having
Right.
heart disease more than the white people.
Yes.
Okay. So we found out 3 reasons.
Right.
So number 1, when we are born,
Right.
there is a hypothesis called thin fat Indian baby hypothesis.
Yeah.
You heard of it?
Yes, but Indian paradox, I have heard of it.
Indian paradox.
Okay.
Indian
The
paradox.
thin Indian paradox.
Thin Indian paradox.
Okay.
So I'll come to that. Okay.
Yeah.
This is when you're born.
Yeah.
When you take a low birth weight. I mean, when you take 2 babies.
Yeah.
South Asian baby.
Yeah.
White baby. So let's say both are 3 kilos.
Right.
With the same weight, the body fat percentage is higher in the Indian baby.
Yes.
Same weight. And that progresses into adulthood, and that is where we end up in getting skinny fat.
Right.
As exactly
Right.
as you say, Indian
Yeah.
obesity paradox
Correct.
is, we call it TOFI.
Uh-huh.
TOFI.
Uh-huh.
TO stands for thin on the outside.
Outside. Fat
FI
inside.
is fat on the inside. TOFI.
Right. Toffee.
TOFI.
Right.
Then what happens is, as you know, when
Yeah.
we eat more calories, more
Yeah.
carbs are getting converted into fat. The first fat accumulation of adipose tissue is right beneath the subcutaneous tissue in the abdomen.
Abdomen.
After that, once it gets filled up, it spills into the visceral fat inside the
Inside.
abdomen.
Yeah.
Deep inside the abdomen, around the organs. The problem with our Indian community is this abdominal compartment is smaller,
Smaller.
significantly smaller compared to other non-Western counterparts.
Right.
So you don't have that much room to store in just subcutaneous tissue.
Right.
You are absolutely predisposed to throw the excess fat into the visceral fat.
Visceral fat.
And as you know, visceral fat
That
is
is
the
the seat. Visceral fat is the seat of insulin resistance, metabolic syndrome.
To start with, we have a problem.
Yeah.
So which means we need to be extra cautious.
Extra cautious and aggressive. That's a very wonderful point. Yeah.
Extra cautious.
Extra cautious. So the genetics remain the same. Even if
Yes.
you are in US,
Correct.
the predisposition remains the same.
Correct.
So you have to be extra cautious.
So we should decrease the masala.
The masala. Yeah. That's a wonderful. Yeah.
So we were. I mean, there's still the research is going
Right.
on. They're finding so many new things.
Yeah.
They have found out that there is 20% increased risk of diabetes in these people
Yes.
compared to Western counterparts, even with a normal diet. I mean, the same amount of diet. So there are lots of research that's
Yeah.
coming out. But bottom line is, we Indian community needs to understand that we are at an increased risk of
Increased.
heart disease compared to any other ethnicity.
Right. Exactly.
Number 1. Number 2, coming back to the same situation where the young patient is
Yeah.
having a heart attack. This is my neighbor.
Yeah.
Okay, my neighbor. We both went to actually. My son's birthday party was the next day.
Mhm.
Me and my neighbor. My neighbor was 36 years old.
Oh.
Okay.
Ah.
See, we both went to the grocery store to buy all this decorations and all those things. In the grocery store, he passed out.
Oh.
He passed out. He complained of chest pain and he passed out. And I tell all these stories, and I myself very surprised that why is this happening to me all the time?
Mhm.
Because I am seeing that patient passing out right in front of me.
Ah.
So I check the pulse. There is no pulse.
Oh.
There is no pulse. So we end up doing CPR.
CPR.
We end up doing CPR. And then the grocery store has an AED machine.
We managed to defibrillate.
Luckily, there was an ambulance right
Outside.
next street or something. So
Yeah.
they call 911,
Yeah.
which is the number to
Right.
call. And then they came, they did the CPR. They shocked him.
Yeah.
And the pulse came back.
Wow. Ah. Fantastic. Yeah.
Massive heart attack.
Massive. Yeah.
Massive heart
Massive.
attack. So I want to ask you, should every person should know at least how to do CPR?
Wow. That's a fantastic thing. We are in the process. The cardiology community, especially in Mumbai, in India, I think so. Hands-on CPR training, we do take out time and try to go to the communities, to the societies
Is that right?
with mannequins.
Huh.
We're doing that, trying to educate
Nice.
because CPR saves life. It saves life, right? The cardiac massage. Unfortunately, we don't have defibrillators, the shocking
Correct,
devices installed, but we are trying. The initiative is there to get it at least at the public places. Railway stations are getting them. The gyms should be getting them.
Correct.
So the housing societies should be getting them.
Correct.
So I think so in the longer run, you have the CPR trained personals, they actually save lives.
Save lives.
So
Big
I
time.
think it's the need of the hour, and with have mushrooming of cath labs where you can actually do procedures. But the point is, if you have a fatal heart attack and near death situation, I think CPR and defibrillation saves. So we have the ABC of resuscitation, airway, breathing and circulation. The D is defibrillation. So defibrillator machines should be encouraged in public places, in malls, in theaters. So the D should be before ABC. That's what we say. CPR. So ABC of CPR is airway, breathing and circulation, but we
D
actually
should be,
trying to get the D in front of A. So
ABC,
you have
okay.
pulseless patient defibrillate and then start
Okay.
with the massage.
So let me just summarize what you said.
Yeah.
Is that CPR is the
Cardiopulmonary resuscitation.
Cardiopulmonary resuscitation. Cardio is heart. Pulmonary is lung. Resuscitation means both are almost dying.
Yes.
Please resuscitate.
Resuscitate.
So the common teaching is that you place two hands.
Yeah.
Like this,
lower
and
part of the
then
sternum.
Lower part of the sternum, and then you keep pressing. And we will put that in the description in terms of what to do.
Yeah.
And while you're doing this, you're doing massaging the heart.
Massaging the heart. Actually trying to.
What happens?
So what happens is, like, what we try to do is while trying to do a CPR and putting pressure in a proper way, obviously the sternum should be lowered, and at the same time the heart is manually compressed, and that gives just enough adequate cardiac output or blood supply, which is adequate enough
until the patient gets to the hospital.
Gets to the hospital. So we continue with the CPR till the time pulse is there and the blood flow. And most important thing is the brain.
The blood flow to the brain.
So the most important thing about CPR is to make sure with the CPR, with whatever massage that you are doing in a proper way, the blood flow is adequate enough. At least the brain is perfused. Ultimately, you treat the attack, but the brain is gone. So CPR,
you've seen patients like that?
Many.
So where there is heart attack, you save the heart, but the brain is gone?
Pressures are okay, everything is okay after that. The brain doesn't come up.
Brain doesn't come back.
So it's important.
When you say brain doesn't come back, they cannot remember who they are.
Absolutely.
Brain dead.
Like almost comatose. Comatose. So I think so. That's a very sad situation.
Because of the heart attack, heart is not able to pump blood, so the brain didn't receive any blood.
So heart can sustain without blood flow. One of the portion of the heart muscle, maybe we talked about the golden hour. 60 to 90 minutes. But brain just gives us 5 minutes. If there is no blood supply to the brain, I think so. It's a very scary situation. Yeah. So CPR is must. We should be inculcating more educational programs and more public awareness through various medias to encourage people to take up that training. We give the certification course also. So any lay person who are actually attend the program are given a certificate as a CPR trainee. So obviously defibrillations again, it should be state sponsored, but they should make that.
So is it available now? Not as much.
It's far and few in between. Yeah. So even malls, crowded places.
Shopping malls should definitely have it.
Yes, I think so. Should
definitely have it.
Every floor should have it.
Every floor should have it.
Yes, I think so. Airports have it. But again, I see it not so frequent. You have to travel like a kilometer before you get to the defibrillator, which is at one of the corners. I think so. More as compared to other countries.
Yes.
I went to Japan or
US.
They are everywhere.
Widely available.
Widely available.
Widely available.
So I think through this forum, I think so we can make and
That's the
probably an
most
appeal
important.
that we can have CPR machines. We can make more, people aware.
Maybe we could spread the message to the audience who are watching is that if you want to donate or if you want to do some charity work, please go to a shopping mall, buy a defibrillator machine, give it to the shopping mall owner and then say, install this in one floor.
Every floor.
You will save so many lives.
So many lives. I think so it's very important. We do a lot of CPR training here on the mannequins. And any society needs it, we go and help them out.
In US, there's a new machine called Lucas machine.
Yeah, I know. Yeah, it's an automatic CPR.
You're lazy.
But maybe
the lazy. I was so surprised.
But actually it helps.
It's pretty good.
It's really good. And Lucas helps.
I'll summarize for the audience. Lucas is a machine that gets trapped onto the chest.
Yes.
So that you don't have to press.
Yes.
The machine presses for himself.
Right. So again, not very widely available in India, but in patients who need prolonged CPR till the time they go to the hospital in a proper way. So there's always a fatigue coming in if you are only 1 or 2 people and you need for 30, 40, 50 minutes.
Machine works.
Yeah, I think so.
So in that patient, so we know we did CPR and then we took the patient to the ER, emergency room.
Fantastic.
Within 90 minutes.
Yeah, fantastic.
I think 54 door to balloon.
Yes.
What do they say? Door to window?
Door to balloon.
Door to balloon. Yeah. Balloon is a stenting.
Yeah.
So door is ER. ER door to the balloon was only 40 minutes.
Fantastic. I think so. That's a great.
So the cardiologist was on call.
Yeah.
Went in. 100% blockage of the left artery.
Wow. And then
they put a stent in. You will not believe the patient. He woke up.
And
it was wonderful.
Went home third day. Probably.
Went home.
Post-probably, yeah.
Went home.
I think so. The whole thing is, our job is easy to put in a stent, balloon, cardiologist. But the important thing here is you got the patient to the hospital through CPR, doing a CPR and defibrillation. That's the most important thing.
Correct.
Without a CPR and defibrillation, he would never have.
Yeah. And this, so once a CPR, so at that time, somebody was mentioning me that, hey, did you have this emergency heart attack kit with you? I said, what is that? He said, no, in India, we do aspirin, statin, clopidogrel. What is that kit? I've not heard about that in US.
No, I think so. I'm not a big fan of all these medications to be kept in. Someone said, like, someone is getting an attack, pop in some sorbitrate. Patient might be having low blood pressure or hypotensive. That sorbitrate may actually worsen. So it doesn't work that way. It's not so simple arrhythmic. But yes, in some doubt, if you are in periphery, kit, I don't know, but aspirin, clopidogrel, we give it till the time a diagnosis or ECG is established. If the patient comes to an ER or if the patient is getting transferred without an ECG with chest pain, we give the benefit of doubt and load the patient in ambulance only with aspirin, clopidogrel. If there is a probability that he is having pain and it could be cardiac. But it can't be used generalized.
It cannot be generalized.
It can't be generalized. The problem is it.
I feel so bad. Or maybe I should have had it. Okay, good. Because it's not generalized.
It's not a generalized idea.
Okay.
It's not a generalized idea, I guess.
Okay. So then you get a CPR and then you could put the stent in.
Yeah.
And then he came back. In the hospital, he was emotional, of course.
Yeah.
The whole family was crying and it was very emotional. And then he was saying that, what could I have done to prevent this? This was almost like a near-death experience.
Near-death experience.
Then I said, what are you talking about? You didn't know about what you were doing? You didn't... I've been telling you repeatedly to slow down. You have been working like crazy.
Right.
You have not slept well. You kept on meeting the time demands.
Yeah.
And the most important thing that happens either ways is, our Indian... I'm just talking about software engineers because my friends are all software engineers. So they work at nighttime to handle with the Indian clients.
Yeah.
And the Indian software engineers work for US clients again at the nighttime.
Nighttime.
Working night shift puts an undue strain on the heart, isn't it?
It is a fact. Your body needs rest.
Needs to rest.
Yeah. You need to have that work-life balance, which is very important, very less talk about. I think so. Stress management by any form. Either you do breathing exercises, meditation, yoga, vipassana. Very important. Strike that balance. Eat well. You work what is needed. And I think so. It's very important to say stop when the body says please stop.
Yeah, exactly. Listen to the body.
Listen to the body.
Listen to the body.
As a younger individuals, we usually try to punch much above our weight.
Of course.
And trying to do human stuff. No,
Because,
I can do many things.
That's the beauty of being an Indian.
We
right?
try to.
Because we have survived in any situation.
Yes, it is.
Right?
Yeah.
We have hustled hard.
Yeah.
We know it is survival of the fittest.
Yeah.
And to a point, that's why in all top 30 software engineering companies, it's all Indian people.
Indian people.
Asian people, Indian people.
Yeah.
But during that time, we have pretty much lost
Yes.
a huge compromise that we have made with the health.
Huge compromise. And it's for the most productive member of the society, most productive member of the family, who suffers?
Family suffers.
So, most productive member gets it. So, when you are doing that extra shifts, when you are doing the long night shifts, without allowing your body to rest, I said, sleep is extremely important and undervalued.
You're not talking about like 1 day, 2 day, 1 month, 2 months.
It's happening over a prolonged period.
Prolonged time.
We are extra ambitious.
1 year, 3 years. Yeah. I'm telling you, all this big startup companies.
Yeah.
They are
huge demands.
Huge demands. And they get paid very well.
They get paid very well.
It comes with a compromise.
But you should know the extent of means that you want.
Right.
We never know the boundary.
Right.
Knowing the boundary.
And just prioritizing your health a little bit will make you...
I think so. It's very important. The Westerners prioritize their health over everything else.
Yes.
We tend to prioritize the material means over health.
Over the work over everything else. Us.
Yeah.
They don't, most of them, they don't work anytime after 5, 6 p.m.
Yes.
We work hard. We are designed to work hard.
We are designed to work hard. That's the point. We actually are...
We grew up, our mindset is like that.
Yes.
And it's very clear, in anywhere, Indian people, we work hard.
Yes.
Asian people, we work hard.
We have to.
So I think that my request is just to understand that there's a compromise.
Yeah.
And maybe doing a little step every day will create some kind of...
Maintaining that balance, prioritizing your health. I think so that should be the takeaways, and listening to your body.
Listening to your body.
Yeah.
So that patient was asking me, he went to India like a month ago. And then he took Master Health Checkup.
Health Checkup plans.
Master Health Checkup. So in Master Health Checkup, there are like so many good things. Cholesterol level, they check. If you are diabetes, they check your eye level. They check your A1C level. Right? What is the thing that should be... should we include anything in the Master Health Checkup for your heart standpoint?
I think very important. So for a 35-year-old, if there are no complaints, we usually do an EKG, ECG, 2D echo, and stress test. But again, as I said, stress test is a matter of probability. If you have the risk factors, it's slightly positive, you investigate further. Treadmill is a screening test. It's not a sure shot test. So
a lot of false positives.
There are false positives, there are false negatives. So we had situations where the patient had a treadmill done last week, normal. Next week comes with an MI. It's MI is myocardial infarction or heart attack for the general public. So nothing is, you can say, 100% sure. Treadmill, all these are screening tests, but still it's worthwhile
to check.
Because it gives you a lot of confidence.
But let me argue that in a way, in US, the guidelines are not recommending to do stress test and echo. So are we doing this over here because the prevalence is higher?
That's also there. Prevalence is higher.
And also the likelihood of misdiagnosis might be higher as well.
Yeah, the prevalence is high and availability is also
Easier.
easier.
Ah.
That's important.
Correct. So I want to make a very
Yeah,
important distinction.
Yeah.
Let's say you are very healthy.
Yes.
That's a problem.
Yeah.
Unfortunately,
Yes, Safa.
in the people that I've
Yeah,
seen
yeah.
in and around my neighbors, my friends, my family, and within my circle, it's a very
Yeah,
limited circle,
yeah.
but let me just say, our community people, they belong to two ends. One, they're extremely fit, they're very health conscious, they're 10 out of 10, and they are like fit, muscular. The other is, we live only
Right.
one life.
Yeah.
Okay, give me the biryani and the beer. I've seen only very minimal people in between.
Yeah.
They are there, but not a lot.
Huh.
So the problem with this master health checkup
Yeah.
is this beer and belly group, biryani group,
Yeah.
they are not going to go to the master health checkup.
Right.
The people who are going to the master health checkup is 10 out of 10.
Right.
So they're very conscious,
Yeah, yeah.
they want to make sure everything is okay.
Everything is okay.
You are not going to find heart disease in
These patients. That's a paradox, right?
It's a paradox.
It is.
So I think probability is as you talked
yeah.
about.
Yeah. The more health conscious you are, the more likelihood that you would be choosing to go for a health checkup.
But in general,
yeah.
everybody should get their lipid profile checked.
Everything. And the basic things should be
Basic
done.
things should be done.
I think so. The basics should be checked. The lipids, the sugars, CBC, basic test, but CBC, thyroid. Yeah, everything should be checked at least once a year. And after the age of 45 for males, for females, and 40 after 40 for males, you should try and do it. We do it treadmill and all every once in 2 years. If family history is there, even more,
then increases the risk
frequently. But it's worthwhile because you at times detect a lot of things.
What is your take on this CT calcification?
Wow.
Okay.
I think so.
Let me tell you the current situation in the US. Okay. So in US, you know how it works, right? You cannot go to a radiology department and then say, okay, no, give me CT scan, right? They'll be like, where is the insurance? Because it's like $3,000, $4,000.
Yeah.
And the insurance, you submit a request, why do you need a CT coronary calcium?
Right.
You're very healthy, you're only 40 years old, we will not approve it.
Yeah.
So then we cannot pay the money of $4,000. You know what we do? We come to India.
Do it CT calcium scoring.
We did a CT calcium scoring for like 5,000 rupees, 6,000 rupees, much cheaper.
Yeah, it is much cheaper.
And we get the results.
Yes.
So many people have done this.
Yes.
Okay. My question is,
right.
Okay, let me tell the audience that CT calcium score is, it's a CT scan of the heart. And remember the blockage that we discussed before of the blood vessels. That whether it is calcified or not will be determined by the CT scan.
Yeah.
In your practice, will you recommend? Yes, no? What does it take?
Yeah. So I think so. CT calcium scoring, I think so. You would be very happy, right? If you have a CT calcium scoring of 0.
Yes. There's no calcium at all.
Yeah. So calcium is a marker for coronary artery disease. Whenever there are plaques
inside the blood vessel,
whenever there are blockages or stenosis, calcium gets deposited, and that's easily visualized. And the radiologist have calculations whereby they ascertain this score is so and so. So you have high calcification means the stenosis or blockage inside the arteries is high enough to deposit calcification.
Yes.
So that's an indirect marker. Secondly, I think so if you get a score of 0, you will be happy. If the score is high, 400 plus, what to do? You don't have symptoms. So whether to do an angiography, I think I would recommend.
Yes.
I think I would recommend if the calcium scoring is high because the blockages are there and the calcium is deposited on top of it.
Correct.
But not necessarily, again I will say, because see as in
you have seen so many people.
So go through so many scans, but not necessarily that high calcium would mean that you will need a bypass or will need an angioplasty. At times it's on the adventitia or the outer layering of the vessel wall also, which can also lead to high calcium scoring. And if your lumen or the vessel lumen is fine, you don't advise. Okay. So, but it's a good screening test for detecting the percentage of calcification, which indirectly indicates the percentage or the burden of atherosclerosis or plaque, the blockages inside. Yesterday, just yesterday, I had a 65-year-old charming lady, no complaints, despite digging, no complaints, treadmill done, positive, in a master health checkup, as you said.
I see.
So that puts me in a dilemma.
Whether we should do an angio or not. Patient has no complaints.
Absolutely no
Master
complaints.
health checkup test is positive.
Now
See, that's the problem.
Fallacy of doing
problem.
a checkup, right? Now she has done it. How can I ascertain whether she has? Now, I mean, it's catch-20. I went to a trek last month, so and so place, no complaints. Now
so the patient is saying that she went to a trekking last time, last month.
65-year-old, no complaints.
So you said trekking because that is an indirect version of stress test.
Stress test.
Because you are climbing up.
No complaints. Trek, no. Treadmill is positive. Now I'm
Very interesting. What do you do?
Now, what to do? I know. Judging. At times people are too keen to do an angio. I can do an angio also based on the treadmill, no problem. But since no complaints, I thought of doing a CT calcium scoring. Fortunately, the CT calcium scoring, despite the treadmill which was positive, which indicating something might be there, the calcium score for her age matched with the age controls is very low. So
you said probably it is false positive.
Let it be. We'll do something whenever there is symptoms. Right now we don't treat the treadmill, we don't treat the ECG. We treat the patient. You note no complaints. Forget the treadmill for a while. The CT calcium score is another test we documented, is on the lower side. You are okay. So I think so it gives you a lot of assurance when the CT calcium score is zero. But the message is, don't be overtly panicked if it's high. It doesn't mean you are going to go for a bypass till the time we do an angiography. It can happen, it correlates, but it's not an absolute correlation. That's important. That's not an absolute correlation. Your calcium score is high, you will get everywhere blockage. No. It might indicate. So it's an indicator. Yeah.
So in that patient, he did a CT calcium score.
Yeah.
Calcium score was intermediate.
Intermediate.
200, 300. So, and then they recommend angio. They recommend angio, but he was like, I'm asymptomatic, why should we? So it's a very, but he was pretty big. Okay. And he had a big belly as well. So because I was involved in masala study, I know that belly fat increases the risk of heart attack, especially in Indian community, because of the abdominal adiposity.
Exactly.
I want to ask you.
Yes.
You've seen so many heart attack patients.
Yes.
So many. What is the percentage of people having belly fat?
I think so, almost 70-80%.
70-80%.
More than that, maybe.
So belly fat causes heart attack.
Visceral fat, that is the seat, what you can say, of insulin resistance. That is the seat of metabolic syndrome. So I think so that's the crux. Even your weight might be 60, but your belly fat and visceral fat, as you said, nicely described, is high. And that's where the problem is.
You have a normal weight.
Yeah, normal weight. Normal weight doesn't mean anything. Your Indians are malnourished. Malnourished, I would say anything which is not balanced is malnourishment. Not undernourishment, malnourishment. They might be eating more, but still they are malnourished. And they have that high adiposity with normal weight. So I think so that calls for attention. And yes, visceral fat, the belly fat, the high, we look at the waist-hip ratio rather than just
body
weight
mass index
is like weight is a number.
Correct.
Look at the waist-hip ratio, look at the waist circumference, look at the visceral fat, and then decide whether the patient needs to be treated aggressively. And most of these patients, as we talked about the dyslipidemia part, so moderate to high LDL, very low HDL, and very, very high triglycerides. Everything is coming from there.
Coming from there.
Yes.
And so that patient had a stent, right?
Stent, huh?
He was asking me, will I get this again?
Wow. Right. I think so. There are, after an angioplasty, there's certain do's and don'ts. Do's meaning you take your blood thinners very religiously, you take your statins very religiously so that there's no new plaque formation inside the.
When you say very religiously, you cannot even miss a day.
Yes, for blood thinners, initially 6 to 9 months, you should not
You
miss.
should not even miss a day.
Miss a day. That's very important. Statins, again, to prevent any kind of plaque progression inside, very important. And whatever the medications needed as per the diabetes or high blood pressure, anything for the low heart pumping also needs to be taken apart from that. Don'ts, I think so very important is do's are important. Don'ts are like obviously the diet, lifestyle, stress relief measures, sleep, everything has to be,
Monitored.
not compromised upon. And there are certain operator dependent also factors. So again, has to be, I believe most of the operators do excellent job, but still.
There is some. But in literature, what is the percentage of
stent
instant thrombosis?
Instant thrombosis is something like clot formation immediately or within 6 months, 9 months the risk is around 1 to 2%. Instant thrombosis. But inside blockage forming inside the stent is instant restenosis. The incidence of that is approximately, you can say, 10% over 10 years.
10% over 10 years.
Approximately.
So if you don't take care of it, the percentage can go up.
Despite doing the best of the things, despite putting in a drug-eluting stent, the best possible one, stents can fail if you are not compliant, if you don't take medications, your lifestyles are not adhered to, and obviously the risk factors remain. Then you can.
So we talked a lot about risk factors.
Yeah.
As a cardiologist, if you have to prioritize all these risk factors prevention, which one will you say the first one? Okay. Number 1 is sleep. Number 2 is physical activity. Number 3 is low carb diet. And number 4 is stress relaxation.
I think so. I will start with the diet first.
Diet first.
Diet first. We talked about mindful eating in the last episode. I think so. That mindful eating is extremely important. Weight is ultimately what they say in the general notions, 80% of what you eat and 20% of physical activity. Ultimately, the calorie deficit will lead to some weight loss over a period of time. I think so 80%, I don't know, maybe certain individuals might be more, but diet, important. Second, I will say physical activity. But not to be lost is very important, sleep. Very important is sleep. At least try to get that 6 to 7 hours.
In your practice, when you talk to people, is lack of sleep is a common thing?
It is. It is an epidemic.
It's an epidemic.
It is an epidemic.
In India?
It is. People are hooked to gadgets.
Hooked to gadgets.
Mobiles. Mobiles while sleeping also. They continue to see their Netflix and Amazon. I think so more than anything else, the proliferation of OTT channels,
the wider availability.
So much content, so much content, and it's addictive. You don't stop at one. I think so that over a period of time eats into your sleeping time. Because ultimately you have to go to work.
Correct.
It's not a weekend every day.
Right.
So it's into your sleep. You have to go to job. Your mental framework is not right. Cumulative effect of this sleep deprivation has lot of metabolic issues, health issues leading from that. And it's I think so if you don't get adequate sleep, lot of inflammatory changes inside the body. It becomes pro-inflammatory, which could be assessed by different markers, and that plays a role in sudden worsening of your existing cardiac condition. Possible. So I think sleep is undervalued.
Undervalued.
And as they say, having adequate sleep is not glamorous anymore.
Yes, of course.
So I think so. Need to
come back.
prioritize.
So, talking about lack of sleep, right?
Yeah.
The worst people
Yeah.
who is not prioritizing sleep
Yeah.
is us
It is. You can't actually
or doctors.
because we carried out. This was a small survey, which may not
You
hold
did a
true.
survey.
Which may not hold true for general. But when you look at 100
Healthcare professionals,
professionals,
nurses, doctors.
the risk of factors, earlier onset of coronary artery disease. Earlier, doctors tend to have health issues, especially the cardiac ones, 5 to 10 years earlier. Lifespan of a doctor is less as compared to general population.
We give lifespan to other people. Ours is less.
I think so. It's important to look inside. And at times we can't do away with the mobiles and all because of professional compulsions. But I think so. Boundary needs to be made.
There was a news that a Gujarat cardiac surgeon.
Yes.
He died at the age of 40.
Earlier than that, I guess.
Earlier than that, 38, something like that. The news was, this wonderful surgeon did 40,000 surgeries. He worked so hard. Yeah. And I can't believe that he died. The reason that he died is because probably he worked too hard.
Right. We glamorize hard work. That's what I say. We glamorize that and we don't glamorize adequate sleep at all.
Correct.
The priorities, the society, he's working hard. Yeah, it's beautiful. But I think so. That thing has to be carefully.
Carefully balanced.
As a healthcare professional, for all young cardiologists coming up to me, I always say, don't do that unless it's necessary. Unless you're jumping from one place, it happens. It's not like Bombay, the practice is different.
Correct.
You jump from one place to another, to the third, to the fourth, earn money. You don't sprint.
It's a marathon. For
young healthcare professionals, you have to run a marathon. You have dedicated so much of time and energy to pick up a skill. And then maybe 13, 14, 15 years, you actually invested so much of time and efforts to get that skill set. You do marathon. You are not here for 100-meter sprints.
Correct.
You will fall. And it happens all the time.
I'm very concerned about the young doctors who's in training.
Yes.
When we were in training in US, we used to go at 7 a.m. in the morning and then come at 1 p.m. the next day. So what people over there, they said was, this is not humanly possible. Yeah. Their concentration focus is going low. These are all young doctors. We need to preserve them. So they removed the extended hours. So ACGME, which is a graduate medical education, they said that, okay, this is something wrong. So we're going to do only 24 hours. Oh. And as soon as the report was out, we were like, did they see what is happening in India? What are you guys doing? We just can't accept the fact that they have reduced the hours because that is something new to us.
Right.
So later, while we were doing it, because I did 36 hours.
Right.
And I can't let the other people do only 24 hours. But I started realizing that their quality of life is much better.
Yes.
It was much better and they were able to focus more on the studies and everything. So I think as a working doctor, after you finish your residency, you can make your own choices.
Yes.
But during the PG training, undergrad training, some people you cannot do it. That's a system limitation.
Yes.
I hope somebody listens to the podcast and changes the system limitation and says that, hey, nobody should not work more than 24 hours.
Exactly. We all went through rigorous training. I think at times brutal training, But that was the need of the hour because the PG seats were less.
Yes.
Now the PG seats, the postgraduate seats have increased, I think so, twice or thrice the number that was before. So the program should be designed and it should be scheduled in a way that is comfortable for the trainee doctor as well, so that he gets adequate training, but at the same time he gets time to focus on his health, studies and academics as well.
Correct.
and everything
together.
I think so. It's very important.
Very important. And these doctors, right now, let's say the system limitation, we can't do anything about it. The government should do something.
Yeah.
But let's say within the limitation,
Yeah.
I strongly urge all the young doctors who are seeing this health podcast to somehow compensate. Let's say that you are working long and you are not able to do. You can compensate by focusing on your diet, mindful eating, as you said. And then maybe whatever sleep that you get, you just focus on the quality
of sleep.
And maybe, instead of taking the elevator, take the steps. And
small steps.
Small steps. Meet to 10,000 steps per day, something like that. All this will help.
Yes.
Will help. So instead of saying that, there's a system limitation, I can't do anything, at least we can try.
At least we can try and do from our side. At least start with eating, do the physical activity, whatever is needed, and most important, try to get that beautiful 6 hours of sleep. Very important.
Most important question. As a cardiologist, how do you take care of your heart?
So, frankly speaking, 6 monthly I do my blood test. That's one thing.
Okay.
Once in a while I walk on the treadmill. So treadmill in the sense, in my own department, I do my stress test. That's one thing. I try to. On off days, I try to be away from the phone as much as I can. I let it lie in one corner somewhere. But it's not always possible. Limitations of the job. So yes, you get your calls at times. You have to wake up. That's a part of professional, you can say, hazard, you can say. I don't know what, but it's there. So I try to, but I try to get that sleep. And most important, we talked about, is like focusing on the diet is very, very important. I don't skip my breakfast. I eat whatever is needed. Lunch is always a working lunch. A dinner with family time, and work-life balance.
You make sure
whatever is possible.
But you prioritize that.
Yes, I think so. Prioritization start at the mental level. And obviously,
you have a daughter. You have a beautiful daughter.
Yeah, you have a beautiful daughter.
So you spend time with her.
I try to as much as I can. She's getting in her teenage years, so she tries to be away from me, but I try to cling to her.
Nice. So, all that helps to decrease the cortisol levels.
I think so. Ultimately, it's the cortisol, adrenaline rush, the inflammation, which plays a role. And I think so this all is less focused on and less talked about, but it's very important.
Beautiful.
Yeah, it's very, very important.
Wonderful.
So,
Wonderful. So I hope with this discussion, at least 1% of the people watching changes.
Yes.
That's a success for us.
That's a success for us. Yes.
That's a success for us.
That is a success for us. Yes.
Thank you again for such a wonderful interview. I'm absolutely floored and amazed by the hard work that you do. Keep doing the good work. We need you. Take care of yourself even more.
Thank you so much.
Thank you for your time.
It was a pleasure being here. Thank you so much.
Thank you. I had so much fun in this episode discussing with Dr. Anup Taksande. I'm sure you learned a lot as well. Again, I don't want you to just move on. Think about what you learned during the podcast. I want you to write down in the comment section so that the writing actually registers the fact in your mind so that you will actually implement it and not just use this as a bystanding video and just a scrolling thing. I don't want you to do that. Okay. So I want you to learn at least 1 or 2 points and hopefully you'll be implementing that not only to yourself but also to your family members so that together we can grow better both physically and also mentally. Thank you for your continued support. Please consider subscribing to my channel Gut Feeling with Dr. Pal Clips and Gut Feeling with Dr. Pal Shorts, 2 separate channels with condensed clips from 8 to 10 minutes and sometimes 1 minute shorts and reels of this clip from the longer 1 hour podcast highlighting the salient features. So if you're a person who wants to listen to the audio format, maybe while you're commuting or while you're driving, we are available in Spotify as well. Please check out the link Gut Feeling with Dr. Pal in Spotify as well. As usual, thank you so much for your continued support. Remember, one belly at a time. It is absolutely important. I'll see you in the next video.